If you ever wondered why your patient was so slow to wake up after anesthesia, this is the tutorial for you. Fundamentals of anesthesiology with me, Pat Nelligan. Understanding gases and vapors. Emergence from anesthesia, part 2. This tutorial will look at other factors that impact emergence from anesthesia. In the previous tutorial, we looked at the tissue blood partition coefficients. They are the fat blood partition coefficient and the muscle blood partition coefficient. And I explained that these coefficients determined at least partially the storage of anesthesia during moderate to long cases. So we discussed that in terms of tissue compartments and then tissue back diffusion at the end of the case. In this tutorial, we're going to look at the other factors: the concentration flow ramp, the duration of surgery, body habitus, hypothermia, hysteresis, other drugs, and then spontaneous breathing versus intermittent positive pressure ventilation. The concentration flow ramp. Gases pass from high partial pressure to low partial pressures. Remember, gases want to escape from one medium to another, and that's determined by partial pressure gradients. The only thing you can really control on your side of the anesthetic apparatus is the alveolar partial pressure. You do this at the end of the case by turning off the volatile agent and increasing the flow. The clearance from the alveoli is determined principally by gas flow and minute ventilation. Here are two scenarios. First, on the left, where there is low flow with or without low minute ventilation. There is still some volatile in the airway. Because none is being inspired, there is a partial pressure gradient to the alveolus, but slow clearance impedes the partial pressure gradient and limited quantities of agent are cleared. Conversely, with high flow and high minute ventilation, the extremely low concentration of the agent in the alveolus increases partial pressure gradients and speeds clearance. So high fresh gas flow reduces rebreathing. It speeds the washout of anesthetic from the circuit to the alveoli. And this is particularly important in spontaneously breathing patients, as you cannot control those patients' alveolar ventilation. What gas should you apply at the end of the operation in order to increase flow? The gas you should use is the gas you use during the operation for the most part. If you're giving an oxygen and air mix, just increase the flow of the oxygen and air mix. And flow is flow, whether oxygen or air or both are administered. For some reason, a lot of anesthesia residents seem to think that giving 100% oxygen at the end of an operation magically sucks gas out of the blood. This is complete nonsense. And it may cause absorption atelectasis that may impair elimination. The practice of giving 100% oxygen at the end of cases, aside from when there are legitimate airway concerns, as well as perhaps concerns about hypoventilation, particularly in the pre-Sugamidex era, it's an artifact from when nitrous oxide was used by all anesthesiologists all the time. They were petrified about a semi-dubious concept known as diffusion hypoxia. But that can't happen if you don't give nitrous, and probably won't happen even if you do. Alveolar ventilation is the single most important controllable factor if the patient is on positive pressure ventilation. There's no question that increased ventilation will lead to faster elimination, and hypoventilation will delay emergence, but hyperventilating the patient may not be as effective as you might imagine for reasons that I'll explain later on. Let's look at cardiac output, and this is important. During emergence, increased cardiac output increases washout of volatile agents as they are being delivered from the tissues back into the blood, particularly from the brain. And it speeds return of consciousness, although the net effect is a balance between more rapid tissue washout and more efficient pulmonary clearance. Low cardiac output slows delivery of agent from the tissues back to the lungs, and although the end tidal concentration may fall, the brain blood lung washout is prolonged and emergence is delayed. The volatile agent that is delivered to the lungs is very efficiently removed if alveolar ventilation is good. Let me show you some examples. In this image, the truck is loaded with sevoflurane from the brain and the tissues, and it travels to the lungs where it's unloaded by the alveoli. There's good cardiac output and good alveolar ventilation, and most of the volatile in this scenario is being removed very efficiently by the lungs. In this image, the cardiac output is low and the volume of volatile anesthetic carried through the lungs is low. And although extraction is high from poorly perfused alveoli, hence the emptiness of the truck, the clearance is actually relatively poor. In this scenario, blood flow is good, but alveolar ventilation is poor. As a consequence, there is no way to clear the volatile agent from the blood as the alveolar and arterial concentrations are equal very rapidly. So the patient stays asleep for a lot longer than you might imagine, even though you've discontinued delivering the volatile agent by the inhalational route. Finally, if tissue stores are high, regardless of alveolar ventilation and cardiac output, the reduction in brain concentration is context sensitive and requires depletion of storage before clearance is effective. The key point I need to make here is that increasing minute ventilation increases clearance from the blood and from the lungs, but not from the tissues. Also, the lungs may not be absolutely normal at the end of the operation. Atelectasis impairs elimination. High inspired oxygen tensions during pre-oxygenation and during the operation causes absorption atelectasis, and poor gas exchange slows washout. So emergence is not about turning the vaporizer off, it's about how fast the lungs clear the anesthetic and how much the body gives back. Let me illustrate this. In this scenario, we have 3 lung units. This lung unit has normal ventilation perfusion matching. This lung unit has high ventilation perfusion ratios, it's relative dead space, and this lung unit has very poor ventilation. It's collapsed, it's atelectatic, but the flow is good. So this is a shunt through the lungs. What happens with the volatile agent? As you can see, there is good flow through the shunt area and through the well perfused, well ventilated area. But overall, the clearance isn't great because the lung units that have a shunt don't clear any volatile agent, and the dead space lung units also don't clear any volatile agent because there's very poor flow. That may occur during anesthesia when you apply PEEP but don't recruit the lungs. Overall, inspired dose and duration of that dose is important. This leads to higher tissue storage, particularly if the tissue blood partition coefficient is relatively high. Turning off the vaporizer does not turn off the anesthetic. Turning down the vaporizer during the operation creates a new steady state. Higher flows and higher minute ventilation speeds removal of agents from tissues to blood to alveoli, but does not impact clearance from the tissues. Now let's look at the duration of surgery and the inspired concentration of vapor. The biggest beginner error that I see in anesthesia is forgetting to turn up the flow when the vaporizer has been turned down or off, particularly if end tidal control is used. This results in persistent inspired vapor and slowness to emerge. During short cases, there is minimal tissue loading. During long cases, there is significant muscle and fat accumulation of volatile agent determined by the tissue blood partition coefficients. In addition, higher inspired dose results in greater load of volatile agent that is stored in these tissues. So high dose, long surgery means slow emergence. The other thing that's really important is body habitus. In obesity, there are increased fat reservoirs, and there's also increased muscle mass or lean body mass, up to about a BMI of 35, and then those two lines separate, and most weight gain beyond a BMI, body mass index, of 35 is pure fat. The presence of very high fat stores in the body means that there is increased tissue storage and prolonged emergence from anesthesia, remembering that the vapor has to get from the fat into the blood. It also has to get from the muscle into the blood, and it back diffuses into the brain and keeps the patient anesthetized for longer, even if you have switched off the vaporizer. For short cases, this doesn't matter. For long cases, tissue storage may be quite significant. Hysteresis is a really important concept in emergence from anesthesia. Volatile agents require higher doses to render a patient anesthetized, in other words, they're slower to go asleep, than to keep the patient in that state. With predictable closing times, and this is one of the great frustrations working in academic medicine, in that sometimes the closing of the wound takes longer than the operation because residents are doing it, whereas consultants or attending surgeons do the main part of the operation. But when there is predictable closing times, careful downward titration of inspired concentration ensures adequate depth of anesthesia despite the patient exhaling only zero point 0.4 to zero point 0.6 of an Fmac. You have probably experienced the phenomenon. On induction, loss of consciousness typically occurs at zero point 0.6 to zero point 0.8 of a Mac, but regaining consciousness, the Mac awake, occurs at a lower level, typically below 0.4%. This is the hysteresis loop that I've previously described, and here is the Mac awake. And you need to be aware of that. You don't need to be that bothered giving the patients lowish inspired concentrations of volatile agent while closure is taking place. Now, the reason for this was previously discussed. It's associated with neural factors. The brain resists the state of transition. This is neural inertia, and it does delay return to consciousness. Our patients get cold in the operating room, and we do all kinds of things to stop this. We put on heated blankets, we give heated fluids, but hypothermia is a problem. Hypothermia increases anesthetic solubility and tissue storage, and that contributes to slower emergence. But the dominant effects are reduced metabolism, reduced ventilation, and reduced central nervous system activity. In the hypothermic patient, you need to administer less volatile anesthetic than you would in a patient who is normothermic. But for the most part, try to avoid allowing your patient get cold. Of course, in modern anesthesia, polypharmacy is practice, and these drugs stack the Mac. Opioids have major effects on all systems in the body. They cause respiratory depression, they're antiadrenergic, they sedate patients, and they delay emergence. Benzodiazepines are sedatives. Often they're given at the beginning of the operation for various reasons. Propofol may have a residual effect. If you're doing a very short case, the patient probably doesn't need a lot of volatile agent. The propofol lasts longer than you might think. Clonidine and dexmedetomidine and ketamine are also major sedatives. And also, not infrequently, if nitrous oxide has been delivered, just turning off the vaporizer doesn't wake the patient up because there's a lot of residual nitrous oxide present. Never ever forget that if you use MAC or FMAC as a target, that all other drugs stack the MAC and unquestionably reduce the amount of volatile required to maintain adequate depth of anesthesia. In addition, these agents may keep the patient behind the sleep barrier. So even if the end tidal sevoflurane, isoflurane, or desflurane is extremely low, the patient may still be asleep from all the other drugs that you've given them. Let's talk about spontaneous ventilation versus intermittent positive pressure ventilation. Traditionally, in anesthesia, when patients were not intubated, spontaneous ventilation was maintained, holding a face mask or early in the era of laryngeal mask airways. These days, a lot of anesthesiologists administer positive pressure ventilation through LMAs because modern anesthetic machines have pressure control ventilation. They also have pressure support. And there are pluses and minuses to using spontaneous ventilation. The big minus is that it's more difficult to achieve the desired FA FI ratio to get that patient up to adequate depth of anesthesia. And usually, anesthesiologists will manually ventilate the patient early in the case just to get that volatile agent into the brain. But once anesthesia has been established, the FI can be adjusted to adequate depth by looking at the tidal volume and the end tidal CO2. If the tidal volumes are low and the end tidal CO2 is high, the patient is probably getting too much anesthesia, so you will dial down the vaporizer. Hypotension is less of a problem during spontaneous ventilation than positive pressure ventilation because of lower mean airway pressures and usually more disciplined targets with the inspired vapor concentration. Frequently, though, during spontaneous ventilation, hypercarbia results that can cause hypotension. It certainly causes a mild respiratory acidosis. It's likely completely harmless, but it is a factor to consider. And the best thing I think about using spontaneous ventilation is that you can progressively wean the anesthesia during the case, and emergence is entirely predictable. With intermittent positive pressure ventilation, volume control, volume guaranteed pressure control, there is much more rapid attainment of the FA FI, allowing precise control of the fractional MAC and the end tidal CO2. But this is more likely to be associated with hypotension due to the higher mean airway pressures. And poor discipline frequently happens with the FI vapor. The anesthesiologists, particularly the very junior ones, tend to be very slow to turn down the vaporizer. They tend to go on autopilot. In the early years of the laryngeal mask airway, there was a lot of concern about increased risk of gastric insufflation and aspiration. I'm dubious about this. I see virtually no cases of gastropulmonary aspiration in my practice, and certainly not in ambulatory surgery in patients who have LMAs unless they are morbidly obese. In addition, it is of course possible to use synchronized intermittent mandatory ventilation or to progress the patient towards spontaneous ventilation towards the end of the case or in the middle of the case. But regardless of what you do, you have to get the patient breathing in order to get them to the recovery room. Also, as I've mentioned, just keep an eye on that mean airway pressure. It will always, always, always be higher in intermittent positive pressure ventilation versus spontaneous breathing. This is particularly the case if you apply positive end expiratory pressure. High mean airway pressures reduce venous return, and PEEP increases alveolar dead space. Let's look at anesthesia strategy if you're going to apply intermittent positive pressure ventilation during the case. This is the typical situation that we have: intravenous induction followed by high FA FI, and then progressive titration downwards of the volatile agent, utilizing the hysteresis loop at the end to turn down the volatile very, very significantly. Ideally, in the middle of the operation, zero point 0.7 of a MAC is where you want to be if you're using balanced anesthesia. A poor strategy would involve giving the patient a high initial inspired dose of volatile agent and failing to turn the inspired concentration down. Thus, you run into big problems with tissue storage, tissue back diffusion, and then hysteresis, and the patient may be extremely slow to emerge. Another strategy, an alternative strategy to utilize what I will discuss in the next tutorial, is the reverse second gas effect. When the major part of surgery is completed, to turn down the vaporizer significantly and replace some of that sevoflurane or isoflurane with nitrous oxide, thus increasing the gradient from fat to blood and reducing the total body storage of volatile agent while ensuring adequate depth of anesthesia. Or you could use desflurane if available. Finally, we've all had this experience where you've turned off the vaporizer and the expired volatile agent falls progressively to zero and the patient just refuses to wake up. Usually they do suddenly after what seems like an eternity, but it's only a few minutes. It can be embarrassing. The cleaners are in the room, everyone's standing around, and you're wondering, Why is my patient not waking up? What's likely going on here is that the fresh gas flow and minute ventilation very efficiently clear the pulmonary blood of volatile agent, but the brain has not yet back equilibrated with the alveoli. Tissue volatile agent is still back diffusing to the brain, so the partial pressure of volatile in the brain is just above the MAC awake. And then when it crosses a critical threshold, there is sudden arousal, reflecting the steep dose response curve that we've seen in the Hill coefficient. The way to avoid this is avoid high levels of tissue storage. Let's review this tutorial. This tutorial was the second of two on emergence from volatile anesthesia. I discussed the concentration flow ramp, the duration of surgery, body habitus, hypothermia, hysteresis, and other drugs, spontaneous breathing versus intermittent positive pressure ventilation. Next time, we're going to start looking at the various gases and vapors that are used in anesthesia, and I'm going to start with the first one, nitrous oxide, its properties, the history of nitrous oxide. And then we look at specific factors that make nitrous oxide a useful drug, the concentration effect, the second gas effect, the max sparing effect, the reverse second gas effect. But I'll then progress on to talk about complications and problems associated with the use of nitrous oxide. I'll see you then, and I guarantee you'll learn something.